across our health plan and CMS. We also have to prioritize every year ourselves. Like, where do we start? How do we prioritize and make sure that we are able to identify, the highest, risk population by still providing the quality of care and keeping up with our front-end test edit process. So we also partner with a natural language processing company that actually takes all of our senior lives and pushes it through this process that identify additional codes that we might not have been able to get to. We leverage this computer learning and linguistic pattern analysis, and it gives us the ability to rapidly validate and select relevant ICD-10 codes. And then when we get the output file, our coders do a 100% audit check, and then we submit those through either alternate submission file or 837 during the sweep time frame. This endeavor typically starts during early December, late November, and then right around the sweep time. So late January and early February, we're sending the output files to our Medicare Advantage health plans. Our next slide, we're going to talk about transparency across health plans and again CMS, and I have Barbara speak to this part of it.
Right, so we try to ensure that all capitated risk-adjusted members are accurately coded, including supporting documentation, and that they are accepted by the health plans and CMS. And because we're under Linda for compliance, and because we're getting all requests from all the health plans for RADV-style audits, where they want to see supportive documentation, our whole focus is not just coding, but was the documentation accurate? But we do go into CO to see where we have potential opportunities for doing a chart review or bring patients in. For example, this diagram here is showing the last time a chronic condition was coded in a given year. So we can use this if we see that it hadn't been coded as of this year, but it was coded last, say, the previous year. We can do it two ways. We can go in and do a chart review and see if we can find documentation that supported it, because a lot of times, sometimes the practitioners will document in the note, but they won't put it on the charging counter or report it, and it never gets to CMS. Or we can do the reverse with this thing. We can say, okay, these patients, when they come in, we don't want to produce a gap in, now we're in 2018. So we can be more proactive with, again, providing what needs to be coded basically in our EHR at the point of service.
We also have a chart audit program. Typically this happens 2 or 4 times a year. Because we also have a natural language processor and all these other initiatives, we determine how many chart audits we're going to do based on the trends that we find. And so that's how we, kind of complete, do our monthly variance reports, and we do a comparative. We use our prevalence report to help us focus the efforts and know who we're going to chase during the time of year. And then we'll, depending on what we have going on, we'll determine which risk adjustment coders will work on which effort.